want to sincerely thank Quill Lawrence for moderating this session. So Quill is the NPR reporter who covers all things military. So if you listen or have ever listened to NPR and listened to anything associated with military veterans, that's Quill Lawrence. And then we have Nick Kovalsky of Perspective Health. They are a brand new startup, but what's really fascinating is they're about to start with a few clinics in Colorado. And I'm sure he'll share about the AI products that they're building. Then we have Ling Shao. Thank you very much for joining us. And Derek Herrera. Quill, the floor is yours.
All right, thank you. Is this on? Yes, it is. Okay. Well, I thank you all for hanging in there. I know it's the end of the first day, long day. And if you need to go get a drink and come back, we'll understand. But bring one for us. I thought I would just start by letting each of you explain really what you're doing now. And I do want to get into how you got there. How you got to the particular product or project that you've been working on. And let's just start with Nick and we can go along.
Test. Okay, cool. So we're doing AI documentation for mental health, and we're focusing right now on substance use. Yeah.
Right. And just tell me, how did you, so what are you doing? What is it that you provide?
So right now, documentation can take anywhere to 20 to 40% of the time at these centers. So we figured out a way to take a conversation and enter it directly into their software, or EMR. That means the conversation that me and you are having right now, it no longer is me typing, looking up, or going at the end of my day to try and do all my documentation.
And tell me, how did you figure out that this was needed?
I worked at a center myself doing administrative work, and me and my co-founder spent 1.5 to 2 years in this space, kind of getting to know the issues, starting our own nonprofit type work before this.
Okay, great. So I'm going to ask each of you this, and I'm hoping also for you folks to jump in with your questions. I find it always makes it easier when we're getting to exactly what the audience wants to know, as opposed to my questions, which are completely uninformed by any experience in startups or tech. So, which you'll notice is I don't understand terminology, et cetera. But Ling, can you tell us also how you got into what you're doing right now?
Sure. My name is Ling Shao. I started my career out in the Army as a nurse. And I'm sharing that background because it makes me enough of a clinician to be dangerous. So when so I worked at United Healthcare, went to the dark side, which United Healthcare, by the way, they're great. They hire a lot of veterans. So if you're transitioning, they're a great place to look. But went to United Healthcare, and while I was there, had 4 sons who are all profoundly on the autism spectrum. And one of the things I noticed as a parent and as a payer is that providers, it was really hard to find high quality providers. And the ones I did find were more focused on trying to figure out how many hours they could bill me for, and less focused on the outcome that they would actually deliver. So and if I put my payer hat on, payers are really aligned actually in this case with parents. They want to pay for high quality performers and clinicians, and they want to pay more for it. So I started this company to really enable value-based contracting, which is paying for performance. And the way we do that is we also have the clinical documentation end of the EMR, which is how providers enter in what the kids are doing. But we use computer vision, so we video the sessions, and while there's data entry, it's actually labeling the video. And then we sell an EMR to providers, and we also sell the data analytics to the insurance companies, so they can tier benefits. So providers actually get paid more when they use our software because they're able to prove that they're high quality providers.
Okay, great. And we're going to be talking a lot about, I think, about electronic medical records, which I think many great geniuses have sort of broken themselves on the rocks trying to figure that out for more than a decade now. So I'm very interested in seeing ways that you guys are actually cracking it. But Derek, tell me what you're up to right now and a little bit of how you got there.
My name is Derek Herrera. I'm the founder and CEO of Bright Euro, and we are a early-stage medical device company based in Orange County, building the most advanced diagnostic devices and software for urology. So for anyone that has voiding dysfunction or bladder issues, we offer the best tools to enable clinicians to ensure you get the right surgeries, the right therapies at the right time. And so I ended up here basically out of personal need and out of a long journey. And so I was a Marine Raider, which, does anybody know what a Marine Raider is in here? Not everybody. So does anybody know what a Navy SEAL is? Army Green Beret. You guys know what those are? Marine Raiders are kind of like that, just run faster, jump higher, smarter, more humble, better looking. No. So I was a Marine Raider. I got injured in Afghanistan. I was paralyzed from the chest down. I was fortunate to survive thanks to the heroism and bravery of my team. And when I came back, I had a lot of challenges. I thought originally my challenges would primarily be focused around mobility, but that wasn't the case. I've had a lot of challenges personally with bladder management and catheter use and all this stuff. And so had an experience where I was exposed to new medical technology that changed my life and decided to take action to try to develop solutions to improve other people's lives, and have had, some success doing that over the past 10 years and will continue to do so, and also advocate for other veterans to enter the healthcare and the med tech industry because it's not always natural or an obvious choice leaving the military, but what I find is a genuine sense of purpose that can unite teams in accomplishing what you want to through the innovation and technology. And so a lot of the industry is very much for profit, so you can make money, but the profit is directly linked to the impact that you have on patients' lives. And so that's why I ended up in neurology, and that's why I'll be here for as long as I can continue to have an impact.
Yeah, I'm really interested in this. Did you, after being a Marine Raider, which is mission-driven to the extreme, did you end up doing any jobs that didn't have that mission attached? Were you in? So tell me about when that light went on that, okay, I need to be doing something that means.
So I was, how I got injured, I was shot and the bullet went into my spine. I was on patrol leading my team in Afghanistan on June of 2012. I was instantly paralyzed from the chest down. Came back and was in the hospital in Tampa, Florida, and had a lot of time on my hands, so I just started applying to school. I was like, well, what am I going to do next? I don't want to be a doctor. I don't want to be a lawyer. Definitely not a lawyer. Like, I'll go to business school. I got classmates that are going to business school. And then I went to business school and, started learning, and one of my classmates was like, hey, Derek, you'd be good at selling stocks. You would make so much money. And I looked at him and I'm like, why? And he's like, didn't you just hear me? You'd make so much money. And I was like, there's just this cultural difference, right, where to him money was a very clear motivator, and that's not a bad thing at all, but it wasn't enough for me, and I wanted to have an impact. And so that experience happened, and about the same time, I became the first person in America to be able to use a personal robotic exoskeleton after it was FDA cleared. And that device enabled me to do something that previously would have been impossible. And so I was able to medically retire from the military without using a wheelchair. So I was able to stand, walk, salute the flag for, what would be my last day in the service. And that all happened because of an innovation created by someone who was just like me. He was a engineer, an inventor who'd gotten injured in a car wreck and started tinkering in his garage. And, years later, he's now created this device that has fundamentally changed the nature of what people are able to do with a spinal cord injury. And so that experience made it tangible and relatable and seemingly possible for me to take action and have an impact in the field. And, been able to do that for the past 10 years.
Yeah, that's great. And we're going to get into some of the nitty-gritty and definitely get to your questions, but I want to ask each of you about being in this medical field and how that's mission-driven for you, either one. If you want to go first, go ahead.
I was an Army medic before this, 4 years, and then 1 year reserve. I've always thought about things and how I can make an impact while, being alive. For me, I actually was in residential treatment as a kid, and one of the things that impacted me the most was a clinician that took, special interest in helping me see that there's other ways to reframe my thoughts. And as I got into, I transferred out of the military and went to University of Chicago. And I realized there's a lot of smart people working to make a difference, and we could start to work together to, create more opportunities for people. And that kind of led me to this path.
What about you, Ling?
Okay, I'm going to be brutally honest. I went into health insurance to make money. And when same thing, I went to Harvard HBS after the military. When we were applying for jobs, definitely had bankers who were like, you can make a lot of money in banking. And I was like, but do you know the best paid CEO actually works at United Healthcare? Makes more money than Jamie Dimon. I'm going to go there because it's a lot fewer hours to make a lot more money. And because I had the nursing background, they were recruiting veterans, especially with clinical backgrounds. So no lie, I went there because I'm like, fewer hours, more pay, awesome. And I felt like, serving in the military, I'd already checked that box of I served my country, I did my, put in my effort, and, I want to kind of coast. But what I really realized when I was there is if you want to change healthcare, you have to understand how people get paid because we live in a capitalist society and no one's going to do anything, no hospital system is going to do anything out of the kindness of their hearts. They're going to do it because they get paid more to do it. And, I loved actually meeting with founders and innovators that were trying to change healthcare. And one of the things that I always wanted to impart with them was, that's great, but somebody has to make more money. Otherwise, they're not going to do this thing that you want them to do. And so it's awesome that I think everyone up here with me has really thought through that kind of math equation. And that's actually what motivated me to go into the startup space, which is how do I help founders and even, kind of my own mission, but I have to do it in a way that people are going to make a lot of money by doing the right thing.
Yeah, so what were some of the cultural differences and some of the lessons you learned going from big corporate to startup and sort of, I think, the sphere that most of the people here are interested in?
I think going from the Army to United was like literally staying in the same place, right? Lots of acronyms, lots of bureaucracy, and then people think you work for a big company that has a lot of money, so you can, not be scrappy, but you still have to be super scrappy. And that's the one thing I think carried over from all of these places is just how to be really scrappy. I don't think you need as much grit working in big corporate as you do being a startup. And definitely the amount of punishment you get at a startup is back like being in the military again. I mean, I feel like I'm emotionally getting shot every day by investors, by customers. And someone, I think Lenore, you interviewed someone up here that's like, this is the worst job because you have to keep a brave face to your investors, to your team, to your customers. And then at the end of the day, you're just kind of holding all of that baggage. But that being able to manage that amount of pain and torture, I think that's the great lesson we all learn from being in the service. That really helps you in the startup world that I don't think you feel as much in the corporate world.
Wow, yeah, that's very valuable.
I have a story to add to that too.
Yeah.
My wife loves this story. So I started my first startup, raised a little bit of money, hired a few people, and then we hired our first guy who had a wife and kids and was a sole provider and a mortgage. Very challenging time. At the same time, just before that, we just had twin boys. And so I had this migraine, like that wouldn't go away on half of my head for like 4 days. And I finally go to the ER and they're like, "Are you under a lot of stress?" And I'm like, "Yeah." And they're like, "Well, this would be normal if you were 65, but you have stress-induced shingles. And so take this medicine, don't touch your kids, whatever." And so then I go back and I tell my wife this, and she's like, "Are you kidding me? You got shot, paralyzed, and almost die. And that didn't faze you. Starting a startup and having kids put you in the hospital." Literally, so to your point, the stress manifests itself the same way, and you felt like you're getting shot at every day, which is...
I hope you're all receiving this as encouragement and not sort of like being scared off. Although I think Ling was saying that would be her advice to everyone, right? To run away screaming.
Yeah. Sorry, this was not the pro VC I was going to say. For the founders in the room, run away. But it really helps if you have a mission, because in the day, like when you're like, why am I doing this to myself? It's not for the money, and right, because so few people make it anyway. It's got to be for something you really, really believe in, and it's got to be with a bunch of people that you really love working with every day, even though like you're getting punched in the face or shot, and everyone's telling you you're stupid, it's not going to work, right? So I mean that amount of grit and punishment is really, I think, important for you to have.
And Nick, I wanted to ask you about, because you were still active duty and were deployed as part of COVID. as the FEMA response, right? I'm just wondering what sort of lessons that you may have brought from that into your work now. It's sort of a unique kind of military deployment.
Yeah, for context, I was a part of one of the first joint Army FEMA missions to set up the camps and to actually deploy the systems and how we were going to do the vaccinations. One of the things that I was most surprised about during that is the people that I had worked with and trained with that I wasn't sure would be willing to do 18-hour days all of a sudden were. We slept on the concrete at times, and it was one of the best experiences of my life, and I was very surprised by that. And I think that actually carries over to what I'm experiencing now in my first couple months of being a funded startup. Is there are days we're up till 4 a.m., and there are days where it feels terrible. But those are also the happiest times, the hardest and the happiest times at the same time. So I think it's about the scrappiness and the grit of even creating a new system and working really hard until it's working.
Right. I'll ask a few more questions, and I want to open up to you all and find out what you want to know about. But in the medical field, you talked about how it's mission-driven. Is it also a place where there's just a lot of opportunity for these kind of innovations that it takes a scrappy startup to do? And go ahead.
Yeah, absolutely. So I'd be interested to hear what the other panelists say as well, but what we see is like an oncoming crisis. There's a huge burden on the system, especially with specialty care providers, and people are getting burnt out, and they're having to deal with more information overload and more patients, and they're retiring. So specific to the urology community, they just can't train them fast enough. There will be a critical shortage of specialty providers in the very near future across the board, and it's even worse outside the U.S., but in the U.S. as well, due to the nature of aging population and all these things. And so what that opportunity creates is a lot of opportunity if you can save time, right? We can spend more money, we can build more things, we can build more buildings, we can try to train more people, but there's a finite amount of time for these types of people. And so if you can help save them time, which I think everybody up here is working on, there's a lot of opportunities.
I agree. I mean, in autism, we already have a critical shortage, so there's just certain, if you live in a rural area, basically you're not going to have access to care at all, which it's just mind-boggling. But we already are in a situation where roughly only 2% of the kids who are diagnosed, and there's a huge underdiagnosis, even receive treatment. So it's already, I agree, there's a crisis coming, it's already happening. The medical profession has also been really resistant to technology and change. So we're really behind the times. We keep the pager and the fax machine businesses in, in business. So, I mean, that's just a ton of opportunities. So if you layer on real technology like AI or real software, none of our EMRs were ever built with kind of a real software or UX UI design in mind, right? Because they're just so old and they haven't been updated. And players like the kind of big tech haven't been able to break in, and so that's just leaving a huge green space right there for anyone to pick up. And I would say the biggest challenge is, how do you have enough grit to fight the bureaucracy to really power through? Because if you do, there's a lot of money to be made and a lot of kind of great missions to be had in there.
I think my personal take is that there is innovations to be made everywhere and anywhere, especially right now. But the thing that's special about healthcare is you get to see it make a difference. And I think EMRs are just one example of an outdated software, but sometimes my co-founders and I, we like to just look around at what's happening around us, and we notice every day that there are systems that could be improved upon, especially with, this past week alone with Operator and R1 and DeepSeek, everybody's creating new technologies that could be applied anywhere. I think personally, working around other healthcare founders, you get to see people that are really excited to make a difference and are really passionate. I think that's the difference.
Yeah, and is it a different moment? I feel like over the last 20 years, I've seen about every other year there's some, story of the tech billionaire who decided, okay, who gets a hangnail, goes to the doctor, it doesn't work out, and says, I'm going to fix this. God damn it, I had to sit in the office for 20 minutes. I'm going to fix this. And then they have just, like I said, they've crashed on the rocks of what was an intractable. I mean, with the EHR, if any of you use VA healthcare, they've been struggling with trying to update their EHR and trying to take they're being now trying to mess theirs with the Pentagon and the private sector. What is it different now? Is AI making it different? Is this the moment where progress can be made?
I think the critical shortage is what's making the difference. I think healthcare has been a barrier in the past. So you've seen, like I said, Microsoft, right? Like Oracle, they're still trying. They bought Cerner, but a lot of the traditional tech companies are not used to is that level of bureaucracy and so much. It's not just the bureaucracy, but regulatory restrictions. Physicians, clinicians tend to be slow adopters of technology. So those things, I think, have traditionally been barriers, but a few things in addition to the kind of crisis of access that we have is also there's a new generation of people that have grown up using smartphones, and they're entering that marketplace. So, when you see these kind of gray-haired physicians retiring, I think you're seeing a lot more clinicians who are desperate to adopt technology. Like trying to explain to a 26-year-old doctor why they have to wear a pager is sort of a weird exercise. So these people they're ready to go, and I would call them digital natives. So as those digital native clinicians enter the field, it's really changing, and then they see that access shortage, right? So patients we're better advocates, we're better connected through social media, and I feel like our parents' generation, they probably weren't as good healthcare advocates as we are. They didn't really question their doctors, versus now I'm like the worst patient. I question everything they're saying.
Because on the internet, you've read the opposite.
Exactly,
and you
yeah.
know better.
WebMD said I had cancer, so I'm coming in here. So I really think that intersection is causing a difference.
Well, all right. Would anyone like to step up to a mic and ask a question? We've got a real brain trust up here, so I shouldn't be the one figuring out what to ask them, please.
Hi. Hi, everyone. I'm Adam, co-founder and CEO of Impress. Ling, you said something that really stood out to me, and is something that I think sometimes I personally, me and my co-founder, struggle with, and I just wonder how you think about it, which is we have a product that is, in our case, a B2C product that is objectively good for society and has an end user because it's B2C, but I guess in our case, it's journalism and trying to make facts more profitable than misinformation and rage bait online. But regardless, the idea here is that, like you said something, which is that the core objective is to make enough money to influence the change. The harsh capitalistic view, which is that if we actually want to influence change in these industries, me walking outside with a picket sign isn't going to do anything. It's make more money than the competitor, or where money comes from in an industry to actually make movement. And sometimes I feel personally like maybe I'm being disingenuous by admitting that. And so when it comes to talking about the mission and the company, how do you think about sort of leaning into the, like you said, almost sort of, I don't want to say fluffy, but the more approachable B2C, this is my end user mission, and hey, I'm trying to actually shake this industry up, and the only way to do that is to change how money's hitting their back pocket.
Right.
And I guess I wonder how you think about that.
So I think maybe the better way to answer is how I present that. So when I'm talking to an investor, for example, they want to hear that you're passionate about the mission, that you're personally invested, you have the experience. But I feel like they're asking me that just to make sure that I have the grit and the self-injurious behavior that I'm willing to do this job. But then they really want to hear how each player in the ecosystem, or how my customers really derive financial value from the thing that I'm giving them, because that's how they're spreadsheeting, why they would invest in me. So it's like, your mission is the kind of the 30-second opener, but then the rest of the hour is really about how you make money and how your customers get value and make money from it. But when you're D2C, it's kind of similar. It's not necessarily how the person makes money, but how you're solving a pain point for them. And I gotta say, I feel like, when you're raising nonprofit money, maybe the mission matters, but I feel like when you're selling D2C, it's really all about how do you improve that person's life and how do you make it as easy as possible for them, right? So it's the mission is really what you say to your own team. I think we spend more time doing that, but yeah.
I was going to say, it's not just for the medtech industry, but what I would say is there's a spectrum, right? And at one end, there's purity and the mission and the impact you have and on the other side is the profit and the finance and everything else. And so, it just changed the level of
Read the
messaging
room.
depending on who you're talking to, right? And it's somewhere on the spectrum, right? So if you're talking to an investor and they're very financially motivated, you're on that end of the spectrum. And if you have a young employee coming out of college who's very, mission oriented, you do both, right? And they're not at odds with each other in this industry, which is pretty cool. And I don't know that that's any different for other industries too. Is it's okay to make money, and we're all here. We should all be here to make money. Otherwise, people wouldn't be here investing in these entities. And so it's not, one thing I had struggled with is that it's not inauthentic or disingenuous to change the way that you talk to people about what you're doing, because they're both true, right? Especially everybody up here, like, you're having an impact and you're making money, right?
Yeah.
And they actually go hand in hand.
That's right. Because if you don't make money, it's not sustainable either, right?
Well, you're not going to make that change, are you? So, yeah. I would thank you guys.
Yeah, go ahead.
Hi, Raj Dave, CFO and co-founder of Scalable Care. We're a healthcare AI platform, and I'm a civilian. Just want to say first, thank you for your service, and enjoyed hearing more about what you're building. Want to hear more about your perspective on how you're using AI in your business and where you see AI going in the next year, in the next 5 years. As a leader of a healthcare AI company, artificial intelligence is actually quite dumb. I don't think you can ever replace people and systems that are built on people. Drones can't replace Air Force fighters. There won't be Terminators to replace soldiers. So how do you see AI being used in the field, in your fields, in your healthcare companies? Do you see it replacing people or giving people more tools to practice at the top of their license? Thank you.
Yeah, thank you. Thanks for your support. For me personally, I believe that we're reconnecting people with the ability to do care instead of focus on things like documentation and administrative processes. And my guess is pretty much anything that doesn't involve a patient and a doctor looking at each other and actually having a conversation will probably be automated within 5 years. Including CRM type processes with calling people and actually hiring someone directly to go through insurance verification with 6 people in hopes that just one comes in. But overall, I think we're all here to enhance patient care. So any sort of AI tools that help with that is where I hope everything is going.
I think all of us here are on that journey of enhancing patient care, but I will say there definitely will be companies that are trying to eliminate some of the interactions. So for example, if you think of triage, basic level, should I go to the hospital? WebMD is not actually a good triage tool, right? Because you always have cancer every time. But true, I would say even ChatGPT now is much, much better than WebMD is at kind of giving that initial triage, because your average person doesn't know. We see patients coming to the ER with diaper rash or heartburn. They should not be there, and actually they're kind of endangering their lives a little bit with all the kind of stuff we have going on in the hospital. So I do see there's some elimination of certain roles, but it's kind of, again, mainly preventing that clinician from doing something they shouldn't be doing in the first place, like triaging someone with diaper rash in the ER, right, or doing paperwork. But I actually see that as kind of the periphery, and that's where I think in the next 1 to 5 years, AI is really going to touch the periphery of healthcare, meaning all the paperwork and all the other stuff that we all want to get rid of. But I think 5+ years from now, it will replace some of your kind of lower level paraprofessionals, and it will I think it will help us scale some of the places where we do have critical infrastructure or access issues. And I don't think that the current system right now is run by leaders who are familiar with technology, right? If you look at your hospital executive team, half of those guys probably can't turn on their iPads, right? Or to have social media. But this next generation, that's where I think it'll be 5 to 10 years out. They're going to start applying AI to the core function. So not just the paperwork, but how do I actually diagnose you? That's actually, I think, the really, really exciting part of where AI. So we're going down the computer vision side because I think, we'll do large language models in the next couple of years, but then it's really about video. So if you want to measure and truly engage in human interactions, you need the video of what the person is doing, not just the text or even the language.
Yeah, so I'm in the device side, and I would challenge what you said. So I think there is a large percentage of the field that can be automated or is already automated. Take radiology, for instance, right? What we provide is typically a niche subspecialty within urology, and we're working to follow the path of, say, like cardiac monitoring. So there's companies that do wearable ECG, and they've developed algorithms that are as good or better than any clinician at interpreting that data. They're more reliable, they don't get tired, so a lot of those things will benefit significantly from AI, and even robotic surgery, right? So some of you guys may be aware of companies like Intuitive, or in our space there's a company called Procept that's automated, a lot of these procedures. And now even the clinicians who've been doing this for 40 years that are good at it are adopting it because they know that this is the future. And so they can do all their preoperative planning and then press a button, and this machine is now, ablating portions of the prostate, and the outcomes are superior, right? And so those are the sorts of things that lead me to challenge some of the assumptions around AI not being able to automate. It's not going to replace 100% of everything in any time, but I would question some of it and which end of the spectrum it's going to be. Similar to like when we were growing up, right? They're like, oh yeah, you need to get a good education because you don't want to be a plumber because a robot's going to be able to do your job. And what's the first types of jobs that get automated with AI? Lawyers, software engineers, right? Whereas plumbing is hard to automate. Like, crawling through, like, that's hard, right? So I would just be cautious and question that, the assumption that there's areas of medicine that humans are just going to be so much better than machines are at, because there's a lot of cases where that's not the case.
Did you want to add something?
Yeah. One thing I've been thinking about is Daniel Ek just raised about, I think, $300 million for a device that is able to just read your body and give diagnosis solutions. And it predicted like 17% of people that had chronic illnesses that was going to affect their life that wasn't possible before, and they were able to get treatment based off of that. And then if you continue down the line of thinking, if that's working, eventually there'll be enough data to automate the treatment planning from there. And I think we can use our minds to figure out where that goes. But I think we're more than 5 years off from that. So.
But I mean, medicine will just be different. Like a pathologist is not going to be sitting there looking at slides, right? That pathologist, their future jobs may be like half, or kind of thinking of parameters for the AI, and half, right, looking at the cases where it couldn't figure it out, or maybe how is it misdiagnosing certain cases. So I think that just the job isn't like eliminated. It's just going to look very, very different with all of this technology augmentation.
Let's take one more question.
Hi, Koma Gandhi, Women's Elite Rugby. I'm curious, dovetailing off of what you just said about the transformation of different types of roles, what does that mean for skills transformation? Because if you think about the way a doctor was trained 30 years ago and the way that they're ending their career of practice is not going to be the way that a doctor entering medical school will be thinking about the practice of their specialty, or clinicians or nurses. So we've sort of touched on it because we all talk about the necessity of keeping the human in the loop at some point. But I'd be curious for your broad perspectives on what that means for skills transformation broadly, whether it's clinicians or people who are adjacent, technology, just top of mind thoughts.
Yeah, I was talking about this with some very, esteemed clinicians, and they told me actually, they said, I'm a world leading clinician in this, and he asked a question of an audience he was talking to, and he said, what percentage of procedures do I do the same way now as I did when I was in my residency and fellowship? The answer was 0. He was trained on laparoscopy and all of these advanced surgical techniques, and he went there to learn all those. And the technology has completely changed what he does. The other thing which I'm excited about is my family, and my mom still does this, she thinks all doctors are great. And newsflash, they're not all great, right? There's a whole spectrum. Does anybody know why you don't go to the hospital in July?
Residents. New residents.
There's new residents, right? They're baby docs. So they've been a doctor for like a day. So don't get sick in July. Don't go to the ER in July, right? Like, I don't say that to diminish the profession, but to your point, someone who was trained or 30 to 40 years, they may not adopt the technology, right? Because they may not be innovative and they may not have the means or the desire or the initiative to do so. And typically those docs are providing for people that may not have access to better care or better resources. I'm excited because if the technology proliferates with things like I was mentioning before, where the technology can automate treatment planning and help provide better outcomes and more consistency across the board, it's going to improve outcomes and improve access to high quality care, which not everybody has.
Yeah, do you want to answer that?
I think a big difference is going to be the willingness to adopt technology. So like the last 30 years, you could have been a doctor. That would have not been like a core skill set maybe someone would have interviewed for. And if I were looking forward 10 years, I can easily see like, you're being interviewed for your role as a, resident somewhere. That would be something that they would ask you is how are you incorporating technology to make yourself more efficient? Because I, as the hospital, want to make more money. So I want to get more, right, out of every minute of your time. And you'll see department heads being pushed, right? Like that's not, like if you were running, right, like the Cleveland Clinic cardiology unit, that probably wasn't something that was like on your KPIs, but I can easily see that changing as you see how much technology can actually increase their top line revenue and right, decrease OpEx. So I think that's a skill that unfortunately I don't know that medical schools train you for right now, but I mean the better performing healthcare systems are, I can foresee that they're going to start putting that in place because they're just going to outperform everybody else because we always complain about how doctors don't make enough money, right? There's too much administration in the system. Nobody wants to do the job anymore. There's so much burnout. So the only way to eliminate the burnout and increase efficiency and frankly get people to do jobs they like doing, which is not documentation, is going to be that adoption of technology.
I have a question for the audience.
Yeah, go ahead.
Is anybody here a founder in healthcare? Does anybody want to be a founder in healthcare? Anybody want to work in healthcare? Yeah? Okay. All right.
I think we
It's a
scared
great
them.
field.
Little research.
It's pretty awesome.
I think we got time for one more question. Yeah, so go ahead.
Oh, so I work in healthcare, so I'm a professor at Johns Hopkins School of Medicine, and I have a research lab in biomedical engineering there. And we started a program about 10 years ago called HexSite, where we have clinicians pitch medical software ideas, and then we pair them with business school students, engineering students, and graphic designers. We train them to launch medical software startups over the course of 16 weeks. And part of that is to think through the different stakeholder roles on a team. And so I'm curious about, for your businesses, the other types of skill sets that you found valuable to your success.
That's a cool program.
Yeah.
I can say I publish in British Medical Journal on it, so I can send you a link if you want to see more.
I'd love to see more. For my team, we have 2 technical and 2 non-technical. We have kind of a mixture of people that have experience in the exact space we're working in, and 2 people that have a lot of history automating processes that are very similar to what we're working on. And we have some mix of business background in there as well. One of the co-founders was running a consulting firm for AI before this. So we got the business expertise with the programming and then kind of the subject matter knowledge.
So I love your program. Would love to hear more about it. And we're probably not as well structured as we have, but we do a lot of cross education. So, and we rotate people through roles. So for example, most of my company is either clinicians or they're software engineers. So we do both things where we make our software engineers sit in clinic settings with the provider and the kid. So they're like on site, and we always threaten them that, we want to get them certified someday to provide the services, because I'm like, you have to eat your own dog food. So you program this thing, you think the person can actually, hit these buttons while a child's trying to bite them. I want to see you do it. And same thing for the other side, which is we rotate our clinicians through, obviously they can't code, but they can do product, right? So they work with engineers to figure out, right, like, how many things can you build in a sprint? Because otherwise they just imagine that these things are all easy to do. and they're really not involved in the process. So on our R&D team, I'd say it's about 1/3 clinicians and 2/3 engineers. And that's really brought this kind of innovation of what you're trying to nurture. And then I'm the evil business person because I'm always trying to explain to them, this is how people make money. But even a little infusion of that is important because it helps our engineers when they're, and our clinical product team, when they're designing, like, what are the things we're going to prioritize? And like, you have to, it's not just what you think is cool, it's how our customers are going to make more money. That's the thing you need to prioritize when building in your feature set. So yeah, exactly what you're doing. I hope more schools are copying you.
Yeah, it sounds like an awesome program. The only thing for me is I would add engineering. So we're a device company, mechanical engineering, electrical engineering, software engineering, and there's a pretty significant gap, right, in the medical device industry because, the best software engineers aren't all signing up to go in the medical device industry. Same way they're not going, well, now they're starting to go in the defense industry, but hopefully we'll get more good software engineers in the medical device industry and the med tech industry.
It's actually been easy to recruit software engineers. I don't know about the other types, but they want to, this kind of younger generation, a lot of them want to work for mission-driven companies, and they want to be able to see and touch the people that they're helping, and that's been really important for them.
Yeah, a lot of people are starting to leave ad tech, right? Like ad tech, so 2010.
All right, well, I think that's all we got time for, and I really want to thank you guys. Oh, is there one more question? I'm sorry, yes.
If you don't mind.
Go ahead.
Thank you for sharing your journey. I just have a question for founders. You guys mentioned that in like next 5 to 10 years, the widespread of AI will dominate like a core function of the patient care, such as like patient triage to routine patient care. Like, what do you guys think of the regulatory or compliance issue that you guys are having currently, and then within the 5 years that that will be mitigated? One, and then how do you guys feel about like adoption? Like, because of the case study, like artificial intelligence requires a data collection from like different case studies, so it requires a HIPAA violation can be happen. So like. It requires a patient's data, which can be sometimes violated with the HIPAA violation. So like, how do you guys like think about these solutions? Thank you.
It's a nice nitty-gritty question.
Yeah, so from the device side, the FDA has draft guidance actually they're publishing, so they're getting up to speed and making it more clear on how you can use devices and AI in devices. And so a lot of the regulatory frameworks are starting to be established, and they're starting to bring smart people into the conversation to help make it easier. But there's a lot of ways, and it's still possible. There's ways to do all the stuff that we're doing and others are doing without violating HIPAA. So it's just a matter of getting the right lawyers and establishing the right contracts, and whether it's a device or software, patients and clinicians agreeing and to either business associate agreements or whatever other types of agreements to enable the compliance needed. So it's happening, right? And it's going to keep happening, and I think it needs to stay that way because, like, what it enables, the path we're following is every single device that's used, even in a commercial setting, we will have the de-identified information, right? And that enables us to amass the largest repository of data, which is actually the only way to get meaningful algorithm development, right? So.
A little bit similar. We pay a lot of legal fees to our law firm for consent forms that, kind of enable us to share identifiable information and use it for research and improving our AI models. But what I worry about is not like the HIPAA violations, because that you can solve with consent forms and good BAs and MSAs. However, what I do worry about, because I have identifiable video, so images of faces, there is a lot of regulations that I think whether the federal or the state government can put in place that really will impede work in that, because it's just getting lumped into like other categories that maybe don't even make sense, and lawmakers don't understand the impact of what they are putting in place. So we de-risk that by, there's a couple ways you can do it. So it's like really knowing when you set up your infrastructure, how to pull out that data. So maybe one state will say, okay, you can't use video or facial recognition of anybody in Indiana, for example. So you just have to have your data clearly labeled enough that you can just wipe that out of the database. But it still doesn't impair it that much, because remember, once you train the model is independent of the data. So you're not selling your model with the data. So if I had to wipe out like all the people in Indiana, fine, right? You still have a big enough data set at the end of the day. And if you fast forward like 5 years, if you think of the amount of data that'll be out there and databases that'll be available, I think regulations will be a hindrance, but it won't stop the movement.
Two things come to mind related to that. One is we launched as a clinical decision support tool, so clinicians have to essentially sign off on anything we create. And I'm not sure if that will change in the future if AI goes through enough research studies and enough policy comes out where it is allowed to make its own decisions, where only one person has to check over certain things enough. The other one is I've been experiencing the HIPAA, just saying the word is scary to a lot of people. So when we're talking about new AI tools in the space, and I'm a younger person, people are instantly worried about regulation and things, and I have to just explain to them essentially that we have the same systems in place as the EMR that they're using. And I think as more tools start to come out, they'll be more comfortable with new innovation and accepting of the structure, I guess.
All right, thank you all so much. This is really super interesting. Thank you all for sticking around.